Reesmer and Cleaver.
This is Jennifer Cont, Adam Resmer, Kelsey Clever, and Allison Worley, bringing you our presentation for Geriatrics. We had case number 8, CVA, Josephine Tyler. This is a description of the case. So the patient is a 78-year-old female who has 5 grown children. Her current onset was she fell in the kitchen and she was rushed to a local hospital by her daughter-in-law. And at the hospital, they diagnosed her with a left middle cerebral artery CVA. Her medical history, she has history of CHF, AFib, hypertension, and osteoporosis for 15 years. She also had an appendectomy around 60 years ago. Those are the list of the medications she's currently on. In her living environment, she currently lives in a mother-in-law apartment off of her son's home, and there's no steps or barriers inside the house. She has a tall shower with a built-in seat, but no any other kind of assisted devices. Her prior level of functioning, she was independent for all functional activities, but she needed assistance with getting her groceries and putting them away and cleaning. Her occupation, she's currently a telephone operator, and she also receives money from her Social Security. And on Mondays and Wednesdays, she likes to drive to the local senior citizen center for needlework and stretch and tone classes. This is the ICF model that we created for her problem. And the main problem under health condition is the left middle cerebral artery, CVA. Under body functions and structures, she has expressive aphasia, decreased active range of motion in the right trunk, right upper extremity, except she has shoulder elevation. She has right lower extremity against gravity, and she has full active range of motion in gravity eliminated positions. She also has decreased strength in the right neck, right trunk, and right lower extremities. She has hypotonicity in the right upper extremity, right trunk, and she has mild hypotonicity in her right lower extremity. She also has decreased sensation throughout her right side, pain in the right glenohumeral joint, edema in the right lower extremity, and decreased static and dynamic balance. And she has trouble with basically all transfers. In the activities column, she's still able to communicate with using a picture board. She's able to self-feed and comb her hair and wash her face. Her limitations are she needs assistance with bathing, oral hygiene, dressing, and toileting. Participation, she can still do any activities with her left hand. Restrictions are driving, needlework class, stretch and tone class. Her internal environment factors, what's positive about that is she has 5 children who can help her, and the son states that his family will pay for any at-home assistance that she needs. And the negative is that she will not be able to attend her needleworking class, and she also will have difficulty with her occupation. For external environment, the positive is she's still able to feed herself and no barriers in the home. The negative is she has decreased amount of income and she can't return to work. All right, some of the problems and goals that our patient has, or that we decided our patient would have. She has expressive aphasia. She has impaired sensation. So a goal for that is to improve kinesthetic awareness and sensation to reduce risk of injury. She has significant pain in the right glenohumeral joint. So our goal for that was to decrease pain to a 3 out of 10 with activity. She has static balance. The patient has impaired static balance in standing, impaired dynamic balance in sitting, and standing as well. So the goal for the patient was to be able to sit using her left upper extremity for support with supervision for 30 seconds to improve static balance, to reduce the risk of falls, to allow her to return home safely. And then lastly, the patient will be able to remain in a seated position with support of the left upper extremity while
anterior, posterior, and medial lateral perturbations are applied for 15 seconds to improve dynamic balance, to reduce the risk of falls, and allow the patient to return home. The patient is also unable to roll in bed without maximum assist to the left and requires moderate assist to the right. In supine to sit, she requires moderate assist with verbal cueing and also requires maximum assist for bridging. Sit to stand, she requires moderate assist, and she requires maximum assist with all other transfers. So our goal would be for the patient to be able to perform all transfers with moderate assistance and minimal verbal cueing using a walker in 3 out of 5 trials to allow for bed mobility. The patient will also be able to perform pressure relief by 2 different strategies with minimal assistance and minimal verbal cueing to decrease the risk of pressure ulcers. The patient is also unable to walk and can propel a wheelchair 50 feet before shortness of breath occurs. So our goal for our patient for walking is the patient will be able to ambulate 15 feet with moderate assistance with minimal verbal cueing using a walker and contact guard assist to allow her to return home. Another goal will be the patient will be able to propel a wheelchair 50 feet without shortness of breath and with minimal assistance and minimal verbal cueing on safety and maneuvering 2 out of 3 trials to allow her to return home. The patient is also unable to perform grooming without setup help and unable to dress herself. So the patient will be able to perform self-hygiene setup with modified independence and minimal verbal cueing 2 out of 3 trials to allow her to groom herself and be as independent as possible. So we decided for our plan of care that we would perform balance, proprioceptive, strengthening, range of motion, and therapeutic exercises. We would use modalities such as e-stim to control pain in her right shoulder. We would do ambulation and transfer training, patient and family education, orthotic and assistive device evaluation and prescription as needed. We thought that we could see the patient 2 times a day for 1 hour per session for 2 weeks and then reevaluate. And for our progression, strength training will be progressed from gravity eliminated to gravity resisted, and then resisted with bands or weights, cuff weights or stuff like that. And then also the physical therapist will provide less assistance throughout the exercises. And then during ambulation training, the physical therapist will provide less verbal cueing and assistance. And these are some of the strategies that we came up with to help our client reach the goals. We would incorporate the family in the interventions, and throughout the treatment sessions show the patient how much progress has been made, enforce that goals need to be met before the patient can return home, and include activities that the patient enjoys, and give small rewards for reaching goals.
From this case study that our patient's rehab potential is fair and that she may encounter some difficulties with her rehab due to the age and some comorbidities that she has. For example, our patient's medical history includes congestive heart failure, AFib, hypertension, and osteoporosis. The congestive heart failure, AFib, and hypertension, depending on medications that she's using for it, you may see some increased fatigue during any treatment sessions. Osteoporosis, you would see there would be more difficulty and more of a safety risk involved with any ambulation or balance activities. Her psychosocial factors actually benefit her rehab potential a little bit. She takes part in weekly social activities at the Senior Citizen Center, both of them. One of them is the stretch and tone class, and then she does needlework. I think she goes twice a week to those. As I said, these would be more favorable in her rehab, and it'll give her something to motivate her to regain her function and continue the weekly stops back down at the senior center. Our patient also, according to the case history, she had a good source of family support, and that she lives near her son's family would help, and they can assist in any caregiving tasks after the discharge. This patient may also encounter some difficulties through a rehab process just due to the age-related changes that normal people go through. The first, in elderly people, they see an increased sway, reduced gait velocity, and reduced tolerance to the conflicting stimuli. So as you age, we generally tend to decrease our ability to correct any different changes in our stimulus, and overall have an increased sway even in static postures. Neurologically, this patient already demonstrates some visual deficits, but she wears glasses to correct the eyesight. And since her somatosensory is limited in the affected arm, this may make it difficult for any compensation techniques that we try. If she has other problems along with her vision, if we're trying to use visual guidance, it may make things different or difficult. And also to go along with the decreased somatosensory that she's experiencing from the CVA, normally as people age they lose vibratory sense anyway, which may not be so difficult for her upper extremity, but when we end up getting her up and get her ambulating, this could cause some conflicts or difficulties with the therapy and progression and affect her rehab potential and ambulation. Compensatory rehab options, as I said earlier, teach her to correct for the loss of sensation in the right arm with visual guidance. She'll definitely have to do more tracking when reaching for objects, and as we first start her ambulation, teach her to track with her eyes any obstacles and watch her foot placement. Restorative rehab options, objective would be to restore the upper extremity tone in her right arm using RUD, NDT, and any general strengthening activities that we could also make functional in nature. Going back to the cognitive deficits, normally patients as they age, they have a reduced ability to learn new motor tasks, and more specifically see a decrease in their explicit memory functions, which will make any remembering of remembering and learning new compensatory techniques or exercises difficult when providing the therapy.
So I did the first article review, and the title of this article was The Relation Between Ashworth Scores and Neuromechanical Measurements of Spasticity Following a Stroke. The purpose of this study was to determine whether the quantitative measures of neural and muscular components, such as intrinsic stiffness and reflex stiffness of spasticity, are valid, and if they are strongly correlated with the modified Ashworth scale, or the MAS. The findings of the study were that there were no correlation between the quantitative measures of the stroke effects and the MAS scale. Therefore, the MAS scale was unreliable and did not provide information about the origins of torque change. The MAS can still be used as a simple, quick clinical tool to measure muscle tone, but it should not be used to monitor progression or improvements during treatment. The type of study this was a cohort study design. The external validity. So the study included specific sample size, so the individuals had to have spasticity for at least 1 year, and it had to be caused from a CVA. And the subjects used, they included both lower and upper extremities. The issue with the external validity is that the authors did not identify if the participants had any other comorbidities that could have possibly affected the study. For the internal validity, the quantitative measurements of intrinsic and reflex stiffness, there was data collected on both the paretic and non-paretic side. So they also compared those results. And the issue with this was they did not take into account the inter-rater reliability. So they had multiple physical therapists doing the MSA assessment. The limitations were that the study was only performed on individuals with CVAs and no other neurological dysfunctions. The study did not take into account whether the participants have any other comorbidities, and the study did not take into account the inter-relater reliability. And topics for potential future research is the validity and reliability of the MAS on individuals with other neurological conditions such as cerebral palsy.
The next article that we used for our paper is the effectiveness of functional electrical stimulation for the treatment of shoulder subluxation and shoulder pain in hemiplegic patients, a randomized controlled trial. The purpose of this study was to determine whether the effect of functional electrical stimulation on shoulder subluxation and shoulder pain in individuals with hemiplegia following a stroke. The findings that they found from this study were that the use of functional electrical stimulation combined with conventional treatment strategies was more beneficial than conventional treatment alone in the treatment of shoulder subluxation and shoulder pain in individuals with hemiplegia post-CVA. This research study was a randomized controlled trial. As far as the external validity of the study went, all patients that were recruited for the study were post-CVA that had hemiplegia. However, one of the downfalls of the external validity of the study was that they did not reassess the effectiveness of FES after the treatment session was over, so long-term effects could not be determined from the study. As far as internal validity goes, they had an intervention group that underwent functional electrical stimulation along with a conventional treatment strategy versus the control group that only underwent conventional treatment strategies. So it was good for the internal validity as far as comparing a treatment group to the control. It also had good inter-rater consistency since all evaluations were conducted by one evaluator. The study also did a good job of making sure that all x-rays that were taken of the patients were done 24 hours post FES treatment to avoid the influence of short-term effects on the data. Also, a few limitations of this study were the lack of specificity of shoulder subluxation in the inclusion criteria. They weren't specific on whether it was a posterior, anterior, inferior, etc. Shoulder subluxation. And they, like I mentioned earlier, did not reassess for the effectiveness of long-term effects from the FES treatment. And also in the inclusion criteria, duration of shoulder pain and subluxation was not considered. So that could have been a limiting factor as far as whether the patient had chronic shoulder subluxation versus acute in the management and success of the study. And then as far as potential future research studies go, like I mentioned earlier, other studies could be done with specific shoulder subluxation application of FES because different subluxation could require different muscle groups to be activated by the FES, and different electrode placement for those specific subluxations could be better treated than by the general protocol that was for every kind of subluxation. So in the future, different studies could investigate the effectiveness of specific applications of FES for a posterior subluxation versus an inferior versus an anterior. And also, Other studies could also investigate the effectiveness of FES applied to other populations that also get shoulder pain and subluxation secondary to hemiplegia.
All right, so my study was called The Effects of Intensive Therapy Using Gait Trainer or Floor Walking Exercises Early After Stroke. The purpose of this study was to analyze the effects of gait therapy for patients after acute stroke in a randomized controlled trial. The findings were it found that walking ability improved more with intensive walk training compared with conventional training. A median functional ambulatory score was 0 at the beginning for all patients, but was 3 in both the walk training groups, and it was only 0.5 in the conventional training group at 3 weeks. Or sorry, not at 3 weeks, at all right, so the median was 0 at the beginning, but then at 3 weeks it was 3 in the walk training groups, and it was just 0.5 at 3 weeks in the conventional training. And then again at 6 months, the functional ambulatory score was 4 in both the walk groups, and it was just 2.5 in the conventional therapy groups. So this study showed that using intensive walk training early in patients with stroke is beneficial for them to be able to return to functional ambulation. And there was some other findings that the study also had, such as between the two categories, the gait training and the walking, the gait training was more efficient as far as it took less time for the therapist to complete, and it also the patients reported a lower RPE score, a Borg rating of perceived exertion. The score was much lower than that versus the walking group. And in the walking group, the patients would just exercise over ground with the help of a therapist and assistive devices and orthotics. And then in the conventional therapy group, it was just 1 to 2 hours of therapy sessions per day. Like I said before, it was a randomized controlled trial. There was 56 patients that were between 3 days post-stroke to 8 days post-stroke, and only 47 completed the study. Some dropped out for various reasons. So the 3 different groups that they used, they put patients, they randomly assigned the patients to those 3 groups. 17 patients were in the gait training body weight supported group, 20 in the walking group, and 10 in the conventional therapy group. And so the patients in the gait training group, they used their body weight was supported, and they walked over a treadmill type setup, and then they also did 55 minutes of therapy to focus on other aspects and other impairments during the treatment. And in the walking group, they were allowed 1 hour to complete 20 minutes of active walking, and then they also did an extra 55 minutes to work on other impairments. And then the conventional therapy group, they just did 1 to 2 hours of therapy to work on all impairments. Some of the measures that were used in the study were the functional ambulatory category, which was the main measure, the Barthel Index, the Scandinavian Stroke Scale, the Borg RPE scale, the 10-meter walk test, and the 6-minute walk test. Some of the limitations of the study were that no formal record of the time used to achieve the 20 minutes of walking during the 1-hour period was taken. So it could have been more accurate with regards to recording time, and also the therapists didn't record the time. The therapists recorded the time used for real practice but not for breaks, and the efforts of the physical therapists were not recorded. So in some instances for the walking groups, the therapists may have provided more assistance than others, so it could have skewed the results a little bit. Some of the topics that I thought would be a good idea for future research were that this study only included those patients that have not had previous strokes, so it would be interesting to see if patients who had had previous strokes would So it would be interesting to see if patients that had had previous strokes would improve at the same rate as those that had just a first-time stroke. Also, it didn't really assess the different types of gait training to determine which method was best. It talked a little bit about it at the end, but it wasn't the main focus of the study. It only talked about 2 different types of training, which was the body weight supported gait training and the walking exercises over ground. It talked about the body weight supported training being better, but it didn't really go into too much detail, so that would be a good study. And then also I had a question on whether how this compared to other studies that looked at patients who were recovering in the subacute and chronic stages, and how that timeline would compare to the acute gait training and the recovery from those impairments.
The title of the 4th article review is Patient-Reported Measures Provide a Unique Insight into Motor Function After Stroke. In this article, the authors used 43 participants that had suffered from a mild ischemic CVA. Overall, the type of study was a longitudinal study that tracked their gain in function over 30 months. The study mainly focused on the usefulness of the standardized items and compared to the patient-reported items in the study. The 2 patient-reported items that they used were stroke impact scale and the motor activity log. The 3 outcome measures that were included in this article that they reviewed were Modified Rankin Scale, National Institutes of Health Stroke Scale, and the Upper Extremity Fugel-Meyer Scale. They use these because these are more commonly seen with the assessments in most stroke patients after the CVA. During the study, the authors used all 5 instruments to assess whether or not or how well a patient had recovered from the stroke. As I said before, the stroke impact scale and the motor activity log. The authors found a sensitivity of both the SIS and the MAL in detecting that a reported decrease in hand function or upper extremity use in patients that had previously been classified as having either minimal impairment or no impairment based on their scores on the Modified Rankin, the National Institutes of Health Stroke Scale, and the Upper Extremity Fugel-Meyer. Validity for this article, as I analyzed it, found to be poor, mainly due to its small sample size of only 43 participants and the fact that it wasn't a randomized controlled trial, it was just a observational longitudinal study. They got their participants just through convenience at the hospital where the study was being done. Internal validity, the article I found had pretty fair internal validity. One thing that they didn't do was correct or assess the previous functional level before the CVA into their analysis. So if any of those patients were more active compared to others that may have been sedentary before the CVA, it could have affected their scores on both the standard scales and the self-reported items. Also, a patient's emotional or cognitive function, or more along the lines of their motivational level, could have been added to assess how many of these patients were actually compliant in their exercises and how many of them attempted to use their affected arm, as I've been seeing that some patients may neglect the affected extremity and just resort to more compensative strategies instead of restorative. Topics of limitations of the study, like I said before, were the small sample size, and also the post-stroke assessment for these patients that ranged all the way from 5 days to some of them were 9.5 years after the initial stroke. Topics of future potential research. You might want to ask or research if there are possible limitations with any of the lower extremity outcome measures of these, as this study showed that there is some limitation with the ones that assess upper extremity function. And also, is there a need for the modified Rankin or the NIHSS or the Fuglemeyer to be revised? That might also be a point of future research.
The following 6 things that are listed are the main take-home messages that we wanted everyone to go home with, or the clinical pearls. So first of all, we wanted everybody to take home that research has shown that SIS and MAL were both sensitive in detecting a reported decrease in hand function or upper extremity use in patients post-CVA. Also, we found that research has shown that the use of functional electrical stimulation combined with conventional treatment strategies was more beneficial than conventional treatment alone in the treatment of shoulder subluxation and shoulder pain in individuals with hemiplegia post-CVA. Other research has shown that MAS can be used as a simple, quick clinical tool to measure muscle tone, but should not be used to monitor progression or improvements from treatment. Finally, the last research study that we looked into found that walking ability improved more with intensive walking training compared with conventional treatment in individuals post-CVA. Another take-home message we wanted everyone to leave with was that a great way to motivate your patients to accomplish their goals in treatment is to do activities in therapy that they really enjoy. And finally, when treating older adults with cognitive deficits, be sure to be clear and concise with instructions and be patient with them as they proceed with their treatment session.
And that concludes our presentation on the CVA case number 8. For Allison, Kelsey, and Jen, I am Adam. Roll Glide.